Our next speaker is a Professor Emeritus of Kanazawa University Department of Radiology. He is Professor Osamu Matsui. His talk will be on microcirculation in HCC, CT pathological correlation and implication for local ablation therapy. Professor.
Thank you. Thank you for your introduction. Thank you for inviting me to this very specialized expert meeting. My title is Microcirculation in hepatocarcinoma, angiography-assisted CT pathological correlation and implication for local ablation therapy. Because this session is for the radiofrequency ablation, I would like to focus on my talk to real safety margin in RFA from the pure point of microcirculation. Before my talk, I would like to briefly mention about technique of angiography-assisted CT for evaluating microcirculation of hepatic tumors. One CT during arterial portography called CTAP, and second CT during hepatic arteriography called CTHA. And we perform for the evaluation of internodular hemodynamics, single level dynamic CTHA, but this is performed very rarely. And in Japan, we have combined CT and DSA system widely. So to perform this technique is not difficult. Recently, CM, CT, and DS system become more and more common in Japan. In CTAP, catheter is inserted into superior mesenteric artery, and contrast medium is infused during the scanning of the entire liver. So by this method, as you can expect, we can evaluate intranodular portal supply very precisely, and also the portal blood flow distribution in the liver. In CTHA, catheter is inserted into common or proper hepatic artery, and contrast medium is infused during the scanning of the liver. So during scanning, we take CT once. This is called early phase or first phase. And after cessation of injection of contrast medium, we also again take CT of liver, and this is called late phase. In single level dynamic CTHA, we inject a small amount of contrast medium, around 10 cc, from hepatic artery, and single level dynamic CT is performed. By this method, we can evaluate the in vivo internodular hemodynamics. So my first topic is blood supply of SCC during multi-step hepatocarcinogenesis and intervention. As already mentioned by Professor Nakashima, there are two types of human hepatocarcinogenesis. One is de novo, maybe, and second is high-grade dysplasia nodule. High-grade dysplasia nodule with very early, well-differentiated SCC foci, and advanced SCC, hypervascular SCC foci, and to moderately or poorly differentiated SCC. And our immunohistochemical analysis reveals that in dysplasia nodule, first, hypoxic-induced factor 1 alpha expressed around the portal tract, and then this induces increased expression of VEGF and its receptors, and sinusoidal capillarization and increased number of unpaired arteries occurs this area, periportal area first. And then gradually, so this in this stage, in imaging, we can probably detect focal hypervascularity. And then this portion gradually expand, spread into the entire liver, and become a classical entirely hypervascular SCC. Our histological analysis shows that there are three types of feeding vessels in these hepatocellular nodules. One is hepatic artery, and the second is portal vein, both included in the normal portal tract. And the other is abnormal artery or unpaired artery, not accompanied by bile duct, probably due to induced by neoplasm. And in accordance with the grade of malignancy of hepatocellular nodules, portal vein and hepatic artery, both included in normal portal tract, gradually decrease. And finally, absent in moderately or poorly differential STC. On the other hand, unpaired artery appeared early stage of hepatocellular carcinoma and acutely increased. And finally, the entire nodule is fed by abnormal artery. So I will show you typical blood supply pattern of nodules, hepatocellular nodules. Typical pattern of high-grade dysphoric nodule is, you can see on CTHA, this nodule shows hypodensity. This means that internodular arterial supply is decreased compared to the surrounding river. And this nodule is not identified on CTAP, indicating almost the same internodular portal supply relative to the surrounding river. And typical blood supply pattern of RSCC is on CTAP, you can see faintly hypodense nodule. This means that portal supply is reserved in the nodule, but not absent. And CTHA, this nodule is not identified, indicating almost the same internodular arterial supply relative to the surrounding river. And well-defined SCC, the blood supply pattern is very heterogeneous. This is one example, but not typical. In this case, the entire nodule shows decreased portal supply and almost the same internodular arterial supply. And focal portion shows definite increased arterial supply and portal perfusion defect. This area shows portal perfusion defect. And moderately differential SCC, the entire nodule fed by artery and extreme hypervascularity and complete portal blood flow depression. So at the early stage of hepatocarcinogenesis, first arterial supply decreased because of the decrease of normal portal tract in the nodule, and then acutely increased by the increase of abnormal artery. On the other hand, the internodular portal supply gradually decreased and finally absent in moderately differential STC. So hypervascular STC with internodular portal supply, such as RSCC or well-defined STC, are not a good candidate for TSE, and maybe RFA is the best choice. So next is drainage blood flow from STC during multi-step hepatocarcinogenesis and intervention. We analyzed the drainage vessel by a combination of CT, angiography-assisted CT, and histology. So we found that intranodular and perinodular hepatic vein decreased and almost disappears from early stage of hepatocarcinogenesis. This is very important because of the blockade of hepatic vein. So drainage vessel from hepatocellular nodules or SCCs changes from first hepatic vein and then hepatic sinusoid at portal vein. And then after capsule is formed, it's changed to portal venular pseudocapsule. I will show you some case. This is a case of borderline to our RSCC. On CTAP, you can see abundant internodular portal supply, and at CTHA, decreased arterial supply, and delayed phase of CTHA, we cannot see any periportal enhancement. And this is a serial specimen. You can see many direct connection between intratumoral sinusoid and hepatic veins. So in RSCC, main feeder is portal vein and through tumor sinusoid, and then they go to hepatic vein. This is a case of hypervascular well to moderately SCC without pseudocapsule. On CTHA, you can see complete portal perfusion defect and markedly increased arterial supply on CTHA, and on delayed phase of CTHA, you can see perinodal enhancement. And there are abundant communication between tumor sinusoid and surrounding hepatic sinusoid. This is one route. And the other route is direct connection between tumor sinusoid and perinodular portal vein or intranodular portal vein. And hepatic vein is almost disappeared in this kind of SCC. So blood supply from hepatic artery through tumor sinusoid, then go to the surrounding sinusoid through this route, or go to surrounding portal vein through this route. This kind of nodule shows a faint swing limb-like enhancement. This is a case of moderate to imaging SCC. In this case, single level dynamic CTHA, you can see small amount of contrast medium first in the tumor and then drain into the surrounding river called coronary enhancement. And this area, you can see tiny portal venule. And there are abundant communication between tumor sinusoid and tumor venule and portal venule in the pseudocapsule. So hepatic artery through tumor sinusoid, and then because hepatic vein and sinusoid communication is blocked, so they reversed to portal vein. This is a schematic presentation: arterial supply, tumor sinusoid, and pseudocapsule, tumor venule, portal venule in capsule, and then spread to the surrounding river, resulting in coronary enhancement. This is very important for RFNA because drainage flow from hypervascular SCC is, as you can expect, this is the first pathway of metastasis of hepatocellular carcinoma and cause of microsatellite and daughter nodule. And local recurrence after RFA is often seen, according to my experience, very often seen in this area. And the drainage area is a rare safety margin of SCC in RFA and should be treated if possible. I'll show you one case. This is a case of relatively large SCC with daughter nodule. You can see daughter nodule is in the drainage area. This is a 3D reconstructed image of this single-level dynamic CTHA tumor, and this green area is the drainage area. And you can see daughter nodule is in drainage area. So according to my experience, daughter nodule are almost exclusively seen in drainage area, in the area of coronary enhancement. As in previous lecture, Professor Nakajima already told, microsatellite regions are very often seen just adjacent to the SCC, even in a small SCC. According to Sasaki, microsatellite regions were seen around 46% of SCC, relatively small, less than 5 centimeters in diameter, around 1 centimeter outside of the tumor. This is very well explained by drainage flow from the tumor, and microsatellites are very frequently seen. So this area is real safety margin and should be treated. I'll show you several cases of local recurrence after RFA in drainage area. This is a relatively large SCC. CTHA shows SCC and drainage area. You can see this is area, drainage area. We performed combined therapy of TACE and then followed by RFA. This nodule shows recurrence here, hypervascular and washout. And this area is completely consistent with this area, as you can see. Another case, this is also relatively large SCC with CTHA shows SCC, and this is drainage area. So we also performed combined therapy of TACE and radiofrequency. This, you can see local recurrence here. This area is just corresponding to this drainage area. Another case, this is small SCC and CTHA, and coronary view shows drainage area protruding into cranial portion of the tumor. After TACE, RFA, you can see complete necrosis of the tumor. But in the cranial area, we can see small, tiny recurrence. This considered to be due to drainage area, due to metastasis through the drainage area, drainage route. So anyway, this drainage area maybe can be called as real safety margin, but I don't know. This naming is only used in our institution. So several problems exist in the application of concept of drainage area as real safety margin in RFA. One important problem is drainage area from hypervascular STC is not always round, but commonly irregular in shape with frequent wedge-shaped protrusion, especially in hypervascular STC with pseudocapsule. I'll show you one case. This is not rare. STC and drainage area is very uneven, and coronal view shows a very strange configuration of drainage area. And this is a sequential view. You can see drainage area is not round. This is common findings. So how can we expect the drainage area by conventional imaging modality? As you know, CT angiography is very not easy to perform. So we can expect the drainage area by conventional imaging. This is one example. We can know drainage flow by careful observation of dynamic CT, arterial phase or late arterial phase or portal phase. We can see faint enhancement surrounding the tumor. This is the same case. You can see definite drainage area, and this area is faintly visualized this on dynamic CT. So we can trace on dynamic CT the drainage area. So this can be real safety margin. Another case, tumor stain, and this is also tumor stain. And in late arterial phase or portal phase, this area, faint enhancement, you can see this is the coronal enhancement, and this may be a real safety margin. So the drainage area, coronal enhancement can be recognized by careful observation of arterial and portal phase of dynamic CT or MRI. So last is how can we project the drainage area on real-time surround image during RFA procedures? I'm not specialized in ultrasound, so previously, doctor in my group published very interesting technique, extracted overlay function on CT, MRI, ultrasonography, fusing image for radiofrequency ablation for hepatocellular carcinoma. They extracted tumor stain and suspected drainage area, and this area can be superimposed on the real-time ultrasound. And they could successful RFA, including safety margin. So I think by the careful observation of the portal or late arterial phase, we can trace the drainage area. So this kind of picture can be superimposed to the ultrasound, real-time ultrasound imaging during RFA. So this is summary of my presentation. RSCC and well-differentiated SCC with internodular portal supply are good candidate for RFA. In hypervascular SCC, the arterial supply, blood flow into the tumor drain to surrounding hepatic sinusoid and through the continuity between tumor sinusoid and portal venules, resulting in a coronal enhancement in the surrounding liver. Coronal enhancement is the real safety margin in radiofrequency ablation. And it can be visualized, but faintly on arterial and portal phase. So, such as extracted overlay function technique may be promising for demonstrating the drainage on virtual ultrasonography in future. Thank you for your attention.
Very interesting talk, Professor. The paper is now open for any comments or questions. I have a question, Professor. In the event that the corona enhancement, will you then advocate ablating the capsule first? Because there are some centers that do not recommend ablation within the tumor itself and only on the capsule, producing a wedge-like surgical strategy for these tumors. Is that a hypothesis that you can get from your concept?
I'm sorry, I can't understand the question exactly, but anyway, simple 5 millimeter or simple, what to say, simple expectation of safety margin is not correct, I think, from the viewpoint of microcirculation. It's very irregular in shape. So, especially in the encapsulated hypervascular STC, more than 3 centimeters in diameter, the drainage area is very uneven and very often partially thick. So anyway, I would like to say simple 5 millimeter or simple.
So in other words, you would recommend a 5 millimeter?
Yeah, I don't think it is enough.
That's
it's
enough.
Very unreliable, I think.
So it will depend on the enhancement pattern of the irregularity.
Yeah, if possible, but it's very difficult.
Okay.
So you said beautiful ablation. For beautiful ablation, you should know the corona enhancement area.
Yeah.
Okay. So, but it's very irregular, and 5 millimeter safety margin is wrong.
Yeah, especially in more than 3 centimeter hypervascularization.
But it's quite difficult to know the exact corona enhancement area.
Yes.
Using usual modality. Mm-hmm. You should do the CTHA if you, you would like to know the exact corona enhancement area.
Yeah. For the exact not identification of drainage area, we need angiography-assisted CT. But as I told in my lecture, maybe we can know in the late early dynamic phase or arterial phase or portal phase, we can see faint enhancement surrounding the tumor. So,
but it's reliable.
Yeah, it's not so. Yeah, I think so. It's a problem.
Tanaka from Japan, and thank you very much for nice presentation. And so, how do we estimate corona area during ablation? And so I have one idea. And so if you indicate your corona area on CT and overlay manually and every slice in a color, and then move to US, and we can detect the overlay method and the corona area during surround the tumor, maybe.
Yeah.
So, and of course, and I would like to try, and you will try to such kind of fusion image. Thank you very much.
Thank you.
Thank you very much, Professor.